Here we go. Good morning, everyone, and welcome to the Buck Institute for Research on Aging. I'm Chris Rebelo. I'm the Senior Director of Communications here. It is my extreme pleasure to welcome you to, I think, what is the 5th event in our Live Better Longer seminar series. Today, important topic, how to become your own geriatrician. So, a couple of we're a hit, John, even before we begin. So, a couple of quick housekeeping notes. If you haven't already done it, please put your phones on silent. And the fire marshal is always happy when I point out the emergency exits at the back of the room. Question, how many of you are new to the Buck? We love having new people here. Please come back. You can sign up for public tours on our website, and that's going to give you a really good insight to a lot of the exciting work that we do here. So, before I introduce today's speaker, I also want to thank our sponsors. They are listed in your program. I also want to make sure you all have note cards that you can write your questions on. If you need additional cards, raise your hand. If you have a question, raise your hand. Volunteers will come and pick those questions up and make sure they get up to me. Special welcome to those of you who are on Zoom. You too get to ask questions. Just put them in the Q&A box on Zoom, and somebody's going to get those questions up to me too. So, it is now my extreme pleasure to introduce Dr. John Newman. In addition to running a lab here at the Buck focused on developing treatments for geriatric symptoms of aging, syndromes of aging, we're going to be talking about that more in a minute. John is also a practicing geriatrician. He takes care of patients at the San Francisco VA Medical Center. His focus there is on preserving mobility and preventing delirium. We're going to be talking about that too. So you can read about John's impressive educational background in your program. I just want you to know how rare and valuable this guy is and how fortunate we are to have him here at the Buck. There is just a small handful of physician researchers in the aging field, so there's not many like John. So in addition to pushing our science forward, and you're going to hear about that, John is also involved in national efforts to develop interventions to help all of us live better longer. And while John is an MD, when he gets up here on the stage, I want you to note that he's not wearing a lab coat and he doesn't have a stethoscope around his neck. So please keep your questions general, things that would be of interest to everybody. And note, the views expressed today are John's only. He's not representing the VA or any other organization. So John, come on up. Let's get started.
Thank you, Chris, for all those kind words.
My pleasure. They're well meant. So before we get started, just want to let you folks know you don't have to worry about taking notes. You don't have to worry about remembering anything. We're gonna send you a link to today's event. You can watch it again at your leisure. And also, I'm gonna give you links to documents, things that you can download. So just sit back, relax, enjoy yourself, and ask good questions. So, John, this event is about giving folks a chance to start thinking like geriatricians. So my first question for you is, what's different about geriatricians? How do they think differently than other docs?
Well, I'm so glad that you're all here. And who's heard of a geriatrician? Oh, wow. Okay, I have to be honest with you guys. When I introduce myself in the hospital as a geriatrician, about 1 in 4 people knows what that means. And then it makes my day. But who's seen a geriatrician? Who's been to a doctor who's a geriatrician? Okay, wow. I'm not surprised. That's a very small number. And that's exactly why you're all here today. And that's why this is so important, because we're thin on the ground. We are the experts in caring for older adults. And we'll talk about what does that actually mean. But there's not nearly enough of us to actually care for all the older adults who could benefit from that. And, to be perfectly honest, I think a lot of younger people could benefit from us too. But there's not enough of us. So we try to cope with that in a number of ways. And one is I want to try to let all of you guys into my brain. I want to try to show you and teach you how I think as a geriatrician, so that you can think a little bit like a geriatrician. And then when you're going and talking to your other doctors, hey, I hope you can find a geriatrician to talk to. But whatever doctors you're talking to, you can kind of teach them a little bit how a geriatrician thinks, and hopefully your health will be better for it. So yeah, what's going on in my brain?
Yes.
So I think there's three things that really define how a geriatrician thinks, and if you can kind of let these three things sink in, you got most of my training already. You don't have to go to residency and fellowship anymore. The three kind of legs of a stool of a geriatrician. One is complexity. We have to be comfortable with complexity. The other two are goals and function. And I'll talk about each of them just briefly, and then we're going to dive into them in more detail. But complexity. So we have to realize that, as we get older, we get more and more complicated. And we can't escape that complexity. Everything affects everything else, whether for good or for bad. So any problem that we're thinking about, we can't just think about that problem in isolation. We can't just think about the kidneys. We can't just think about the brain. We need to think about how everything interacts with everything else. And that can be a bad thing, because you've probably all seen in your lives when one seemingly small event starts somebody on a downward spiral, and then they're never the same person again. We're going to talk about how you can stop those spirals, how you can prevent that, especially when people are in the hospital. But it can be a good thing too. So some of the most satisfying moments in my career as a geriatrician have been when I find that one thing, that one seemingly insignificant thing. Maybe it's stopping one medicine, or it's starting the right medicine, or it's figuring out how to fix something in someone's life that's not a medicine, that little bit of assistance, or that one device that starts an upward spiral, and everything interacts with everything else, and suddenly 6 months later, that's a different person with a new lease on life. So complexity, we have to embrace complexity. And that ties into goals. So when everything affects everything else, you have to think about, what is the most important thing I'm trying to accomplish? And how does everything I'm doing lead towards that goal? Everything has to have a purpose. We don't like just treating numbers for the sake of treating numbers, or prescribing a medicine because we can prescribe a medicine. But what's the purpose? What are we trying to accomplish? And that's up to you guys. So what's your goal? What do you want out of your healthcare? What's most important to you in your life? What do you want to maintain? What do you want to improve? And then together we work out how to optimize, personalize your medical care to reach that goal. Because we can't do everything. If we try to do everything, we're going to do more harm than good usually. So we need to prioritize, and we prioritize towards your goals. Everything has a purpose. It's all about the whole person. We can't avoid that in geriatrics. We're always thinking about the whole person. And they're your goals, and I have my goals too. My goals usually are about trying to improve your health in meaningful, measurable ways. And that's where function comes in, the last of those three pillars: complexity, goals, and function. How do I know that I'm doing a good job? How do I know that you're on a good trajectory? Well, if your function is good and improving, then probably we're doing something right. If your function is going downhill, then something's not going right. And whatever else is going on, we need to reverse that. What does function mean? Function is your ability to do the things that you want to do, your ability to do the things that you need to do in day-to-day life. This is how geriatricians measure someone's health. Can you do the basic things that you need to do day to day? Things like getting dressed, getting to the toilet, getting up off of a chair and walking. If you suddenly have a problem doing one of those things that you used to be able to do yourself, that's a huge waving red flag that something's not going right and we need to fix it. So function, we always think about function. And function, we think about the more complicated level of function too. So can you do things like navigating the public transportation system or driving or managing your finances, managing your medicine appointments? If you're suddenly having trouble with something like that, we need to figure out why. If we're doing something, trying to help some other problem that's causing you to have trouble with basic function, then that's not the right thing, and we need to change course. Okay. So we keep track of function in order to make sure we're meeting your goals as we're managing this complexity.
Great. So briefly, let us talk about geriatric syndromes, because you look at that in your lab too.
Yeah, geriatric syndromes are kind of, put all this stuff into a blender, especially the complexity, and what comes out are geriatric syndromes. This is the core of what geriatricians diagnose and treat. These are complex, multi-system, multi-organ, multifactorial problems. They're big problems, common problems. Things like falls. Falls are a huge problem. They can really change someone's life, and usually not for the better. What causes a fall? Well, if you ask someone who just fell, they might say, well, I tripped on the curb, or the cat ran under my foot. And yeah, maybe that's one of the contributors, but there's a lot more usually that goes into that fall. There's the vision, not being able to see where the step is. There's the balance, which has gotten worse, maybe because of a new medication, or maybe someone who's feeling lightheaded because of a side effect, or just getting gradually weaker over time. Maybe they just got out of the hospital and they weren't moving enough, and now they're weaker, and they weren't able to catch themselves when they fell. Maybe it's the atrial fibrillation, or it's the tremor from Parkinson's disease. Lots of things go into a fall. So if you want to try to prevent people from falling, you have to think about all those different things that might have gone into it and try to figure out what are the most important ones, prioritizing, and try to fix those. And then you can help people not fall. So this is similar for other common geriatric syndromes like delirium that we're going to talk about, or frailty. Multi-system complex problems. And this stuff, it sounds like it's so complicated. How could you possibly figure it out? How could you possibly make a difference? But we can. We can by thinking about it systematically. All of the organs that affect that problem, all of the different medications, all the things in your environment, the assistive devices you have, the way your home is laid out. All these are the caregiving help you have, the support you have at home. So we have to think about all those things systematically. But if we do that in kind of an algorithm-based way, we can help geriatric syndromes. We can prevent them. We can make them better. It has to be this multifactorial thinking, multifactorial intervention for a multifactorial problem.
That's great. So I'm expecting lots of questions. I think our conversation might bounce around a bit today. I'm going to bring it back to these four things. So there is a fairly new national initiative that is focused on age-friendly health systems. I actually think it might be an antidote to our lack of geriatricians. So there are 4 M's: what matters, medication, your mind, and your mobility. And these are all things that you should think about and be prepared to discuss with your doctor. So it's like this is a chance for folks to be proactive with their health. So we're going to talk about all 4 of these, but I want to get started on medication because I think it's so important. People can really get in big trouble. So you will, you're going to get the age-friendly health system checklist. So you'll be able to download it and hopefully even give your doctor a copy of it. And you're going to be able to download this cheat sheet about medications for older adults. So you'll get it. So John, 10 medications older adults should avoid or use with caution. I want to talk about a couple of them. Out of the medications that older adults take, what drives you crazy the most?
Benadryl. Over-the-counter sleep aids, over-the-counter allergy meds. If you remember one thing from this hour, don't take Benadryl, or be very careful with similar medicines that have anticholinergic effects. And we'll talk more about that in a second.
Okay.
Um, it is important to say that medicines can be the source of problems for older adults, and a lot of what goes into being a good geriatrician is trying to limit those problems and instead make sure that the medicines are helping, because the right medicines do a world of good. And I do want to emphasize that before we start talking about which medicines to avoid and how to be careful with medicines.
So go ahead. Oh, the other one I want to talk about is the first one on this list, non-steroidal anti-inflammatory drugs. So I'm noticing that one of the byproducts of aging tends to be pain. And right? And a lot of us deal with that. And here it says that I'm supposed to use Advil and ibuprofen and all that stuff with caution. So what's the deal with that, and how do we deal with pain?
These are another example of medicines that they may be good medicines for some people in some circumstances, but in general, for older adults, because of the way our bodies change, because the way that they affect our bodies change, there are things that we should be really careful with. And usually there are better alternatives. There are things that are safer and work at least as well or better. And that's true for allergy medicines, for example, Benadryl, anticholinergics. So these are drugs that have some kind of sedating effect. So you find them in Tylenol PM. You find them in nighttime cold medicines. Find them in over-the-counter sleep aids, diphenhydramine and others. There are other medicines that fall in that class too. Probably no one knows what anticholinergic means when I say that. But you can look up online on this list from the American Geriatric Society what are some common medicines that fall in this class. And it includes some antidepressants, not all of them, but just some. It includes some acid blockers for your stomach, again, just some of them. Medicines for overactive bladder. I mean, that's a whole class of medicines just for older adults, but they inherently have this effect on your brain. And the effect on your brain is nothing to sneeze at. So these medicines can in the short term, you take them and they make you drowsy, but they can also make you confused. They can trigger delirium, full-blown delirium, like we're going to talk about, which is a huge problem. And so that can cause falls, it can cause confusion. But over the long term, those effects add up. We're learning now that the amount of these medicines, anticholinergics, that you take over your entire life can affect your risk for dementia later in life. And this is terrifying, but I think it's worth saying to you guys. One big study showed that about 10% of all of dementia in the US might be related to taking anticholinergic drugs across the lifetime. So really something to be careful about. And there's safer alternatives. If you need an allergy medicine, there's steroid nose sprays. I love steroid nose sprays. They don't affect your brain at all, and they work really well for allergies and for colds. There's non-sedating allergy medicines. These are similar drugs, but they don't get into your brain as much. Not quite as safe as the nose sprays, but a lot safer than something like Benadryl. And the same is true for pain medicines.
Oh, good, pain. I wanted to get back to pain. I have a personal interest. So, is there something that we can do that makes those anti-inflammatories safer, or are there alternatives?
Well, you think about, first of all, let's go back to goals and priorities. So what's the goal in treating pain? No one wants to have pain. Many of us live with pain. But what's the purpose? So what are you trying to accomplish? Usually you're thinking about, what is the pain stopping me from doing? And how can I not let it stop me from doing what I want to do? So that's the goal of treating the pain. Let me do what I want to do with my life. Often making the pain go away entirely is not a realistic goal, but you should be able to make sure the pain's not preventing you from doing what you want to do. So what kind of tools can you use to achieve that? And there's a lot of them usually. And you start with the safest ones, which may also be the most effective ones, and kind of work your way up as you need to achieve your goal. So NSAIDs, for example, non-steroidal anti-inflammatories, some of these come in topical forms. So as gels that you put directly on where it is you're having your pain. And that's a lot safer than taking them as pills. Tylenol is a really safe drug, unless you take way too much of it. But Tylenol is a very, very safe drug for pain. Often you can relieve pain in joints by strengthening the muscles around it. Exercise, physical therapy can be really helpful. Support for joints. Knee braces definitely don't affect your thinking, don't affect your heart. Knee braces are pretty safe. So think about all the different ways that you can attack that pain from every angle. And then at some point, if you need to, you'll be getting into potentially more risky things like NSAIDs. The trouble with NSAIDs is they can affect your heart, they can affect your kidneys, they can raise your blood pressure, and they're a big cause of bleeding in your gut, life-threatening stomach bleeding. Now, that doesn't mean that no one should ever take them. Maybe those risks are worth it if you really need something else to help you walk, because it's so important to be able to walk, and that's worth the risk. But that's the kind of conversation that you have with your doctor. What's my goal? What are all the different tools I can use to achieve that? And if we start talking about really, balancing risks and benefits and harms, well, sometimes the goals are so important that I'm willing to take some risks.
So that's a combination of those 4 M's, the matter and the medication, like what matters to you. So why are side effects worse for those of us who are older adults?
Yeah, why do we have to worry more about medicines? Well, one reason we worry more about medicines is because we wind up taking more of them. And sometimes more of a good thing is not a good thing. You can have too much of a good thing. There's a word for this, for medicines. It's called polypharmacy. That's a kind of scary sounding word. It literally means too many pills. And it's a word for what happens when you're taking so many pills that some of them are probably hurting you. And you would actually be better off if you took a couple of them away. That's called deprescribing. And that's one of the cutting edge areas of research in geriatrics. Believe it or not, how can we help people be healthier, more functional, feel better, do better by taking away the wrong medicine while leaving them on the right medicines? So that's always something to talk about your doctor with. Can I do more, maybe with less? And but why do we have to worry about all this stuff in the first place? Because our bodies change as we age, and change in ways that we understand and that we know affect how our bodies interact with medicines. So some of the common ways are that our kidney function gradually changes as we get older. And so if medicines are metabolized, if they're cleared through the kidney, and your kidneys aren't working as well as 20 years ago, well, suddenly you're taking a higher dose without realizing it. So maybe you need to adjust that dose down. Our body composition changes. As much as we would like to try, we wind up losing muscle gradually as we get older. Exercise is the best way to slow that. But we gradually lose muscle and we gradually replace that with fat. And that changes how our bodies absorb and react to medicines. So again, you might suddenly be taking a lower dose than you need without realizing it, or taking too much without realizing it. So as our bodies change, we need to adjust the medicines to match.
So this, I think, may be the most important slide of all. A new symptom is a medication side effect until proven otherwise. So explain this prescribing cascade, John.
This was taught me when I was a first-year geriatric medicine fellow by one of my mentors in clinic, who it turned out a few years later is on the national committee that helps to update the Beers criteria, the list of medications that one should be careful with. So I was getting advice from a world expert in this. And what he said to me was, when someone comes in with a new symptom and you're not sure what's causing it, assume it might be a medication side effect until you prove otherwise. So make sure you're being really careful of finding out exactly what they're taking, what's changed, if anything has changed in their life or their bodies that would affect how they're processing medications. Because even if their medicines have stayed the same, their bodies might have changed, and so now they're experiencing a side effect that they weren't 10 years ago. And boy, the simplest and most rewarding thing that you can do as a doctor is make someone feel better by stopping or changing one of their medicines.
So you want to go through this cascade, like this particular case? What happened?
Because often if we don't think that way, our instinct is to treat a new problem with a new medicine. And then that causes a problem and you add another medicine. So for example, someone's blood pressure is high and you want it lower. That's a really good thing. That's, lowering older adults, lowering your blood pressure to what it should be. And that's the same generally as for younger people, by the way. We now know through large studies that older people's blood pressure should be about the same as younger people's. And if you do that, you can reduce your risk of dying by a third. Huge, huge benefit from lowering your blood pressure. But here, okay, so we're trying a new blood pressure medicine. 2 weeks later, a person comes in with leg swelling. Oh, that's not a good thing. That could be a sign of heart failure. And maybe we need to prescribe a water pill to treat that leg swelling. So we prescribe a water pill. Next time the person comes in a couple weeks later, and now they can't hold on to their urine. They're incontinent. And now they don't want to leave their house because they're afraid of having accidents. And maybe they got a urinary tract infection. Well, there's medicines for that too. So we'll prescribe them a medicine for overactive bladder to treat their incontinence. And 2 weeks later, their wife, their husband, their spouse comes in and brings them in and says, I think they might have dementia. Suddenly their memory's not good. They're getting confused. They're not sure, we got lost. And now you send them to memory clinic to get diagnosed with dementia. But all of these things were just side effects of the medicine. Leg swelling is a common side effect of one blood pressure medicine. Incontinence is a common side effect of water pills. And confusion is a common side effect of bladder medicines, anticholinergics. So you could have prevented this whole thing by just changing the blood pressure medicine when you realized, oh, that leg swelling, your heart's fine. That's just a side effect of that medicine, and I'll switch it. And it goes away, and now you're fine. So this is the nightmare scenario for geriatricians. And we feel like this is the sort of thing that this is our job to stop. And I hope I'm empowering you guys to think about, especially if I've just changed a medicine or added a new medicine and then a new problem crops up, think about and talk with your doctor about maybe we just need to switch that medicine up. And hopefully we're not going to go down a downward spiral of adding new things to treat problems that we could have fixed really simply in the first place. So avoid prescribing cascades.
So let's talk a minute about what may be the hardest, most difficult thing for us to deal with is coming up with what matters. Like really before you go see that doctor, you have a clear idea. So can you talk about how that factors into what you do?
It's everything about what we do, because like I started in the beginning, everything has to have a purpose. You don't have surgery just for the sake of having surgery. You don't start a medicine to treat a number unless there's a greater purpose behind that. And how do we know what that purpose is? That's your goals. So really think about what's most important in your life. What do you most want to maintain? What do you want to try to get back? And those are the goals of your medical care. So that may be as big picture as I want to be able to live independently in my home as long as possible. And then there'll be choices about what sort of therapies for what kind of conditions that might make it more or less likely that you could stay in your own home safely. So you're going to pick the ones that help you stay in your home safely. Or, in a smaller way, I want to be able to play tennis. I want to be able to pick up my grandkid. I want to be able to go for hikes with my dog. So the way I'm going to treat my pain or my joint problems or my heart problems is going to be towards those goals, because I want to be able to keep doing the things I most want to do in life. That's the big picture. But then I also think about what matters to you in every decision that you're making. What's the purpose of that? So if you're thinking about a surgery, you have some problem that there is a way a surgeon can try to fix that problem. Well, is that the right approach for you? Maybe it is, and maybe it isn't. How do you know? Well, what is that surgery meant to accomplish? What is it going to do for you? Is it going to make you feel better? Is it going to help you walk better? Is it going to reduce your risk of dying suddenly? What is the goal of that? And then how does that fit with your big picture goals? If I'm having my joint replaced because I want to be able to walk better, well, that may be really important. And so it's worth having that surgery. If I'm not sure how the goal of the surgery fits in with my big picture, then maybe that's not the right approach for me. And maybe I should be thinking about other ways of doing things.
And,
So what matters?
and also matters can be like, I want to be able to go fishing again, right?
Sure.
Or I want to go to my granddaughter's wedding. So
Yeah.
it's like we need to really take some time before we go to the doctor's office to get clear on what the heck really matters to us, short term, long term, right?
Yeah. I remember when I was a fellow, one of the patients I was privileged to help, who lived in a nursing home, and had lots of medical problems. He had problems with his heart, with his kidneys. He was on oxygen, all sorts of medicines. He really wanted to go to his daughter's wedding in Philadelphia from San Francisco. But this was an important life event for him. And it would have been so easy to say, it's just impossible. But that's not what we did. We wanted to meet his goal. Our job as his doctors and nurses was to meet his goals. So we figured out, it took a long time, but we figured out how to adjust his medication regimens, how to work with the airline, with the oxygen, how to make sure that he was set up on both ends of the trip. And we made it happen. And that felt so good to me. We were doing his medical care in a way that preserved his health, but also helped him meet the goals that were really important to him.
That's great. So now we're going to talk about going to the hospital, but we're going to include information about mobility here. So question, how many of you have had the opportunity of spending a night or two in a hospital? Okie dokie. How many of you have been or are currently the advocate of an older person who may or may not have to go to the hospital? Who's been in that position? Great. Okay, so John, you work in the hospital. Talk about the dangers of being in the hospital.
Well, a hospital is a good place to be if you really need to be there. But even so, you want to make sure that it's doing more good than harm. And purpose and goals and function. This is where it all comes together for me. If you have a bad pneumonia, life-threatening pneumonia, you need to be in the hospital for antibiotics, for oxygen, for other stuff. The hospital is the right place for you. But if we fix your pneumonia and you walked in the hospital and you leave the hospital on a gurney to go to a nursing home because you're so weak you can't walk anymore and you're so confused from delirium that you can't take care of yourself anymore, that's not a win. It doesn't really matter at that point that we cured the pneumonia because we didn't help you as a person, as a whole person. We certainly didn't meet your goals. So if you're in the hospital, we want to make sure that you leave the hospital in better shape than before you got sick, or at least in the same shape, that you've maintained your function. And that can be really hard. Hospitals, the illness around a hospitalization is when a lot of people become permanently disabled. And some of that is preventable. Some of that's preventable. So a lot of you guys have spent a couple nights in the hospital at some point. Raise your hand if you spent more time in bed in the hospital than you usually do at home. Okay, so I'm not surprised. This has been measured in studies. People like you, people who walk around, who live independently, who take care of themselves, you go into a hospital and you will spend more than 80% of the time in the hospital in bed. And do the math there. That's like 20 out of 24 hours a day in bed. I bet none of you spend 20 hours a day in bed in your normal lives. And some people even think they're supposed to be in bed in the hospital. Absolutely not. You're supposed to be at least as active as you are in your day-to-day life because you'll lose muscle so fast when you're lying in bed in the hospital. So fast, you could measure that day by day, about 1 to 3% less strength per day if you're lying in bed in the hospital. That adds up really fast. My favorite teaching point for my residents when I'm telling them how important it is to be out of bed in the hospital is that one day in the hospital like that is the equivalent of your muscles getting a year older. A year. And it's going to take time to recover from that afterwards. So immobility is a huge problem, and it has a seemingly simple sounding solution. Don't be in bed so much. Make sure you walk. But that's actually really hard to do sometimes in the hospital. And that's where you have to advocate for yourself. And your advocate has to help advocate for you that you should be out of bed. You should be in a chair at least. You should be walking around. You should be getting exercise when you're in the hospital. And the other things that are happening to treat your medical problems should not get in the way of that. That's the most important thing, and that's the hardest thing to do. That's where the 4Ms and an age-friendly health system come into play. Because if the hospital is designed so that the rest of the medical care doesn't get in the way of you being mobile and being able to walk, then it's a lot easier for for you to stay mobile and stay healthy. Um, but if you have to, kind of negotiate with the nurses and the doctors to when to do this, and it can be a lot more difficult. So hospitals that are experienced in caring for older people, who specifically have programs to help older people, like hospital elder life programs or acute care for elders units. These are places that they build this stuff into the DNA of the units. So people are walking around, people are interacting with each other. People are allowed to sleep at night. Right? Now, hey, sometimes every once in a while, there is a really good reason to wake someone up in the hospital in the middle of the night, but often there isn't. And in getting a good night's sleep, having natural light during the day, talking to other people, being careful with medicines, these are all things that can help protect you from both immobility and delirium.
Yeah, talk about delirium.
Delirium, the brain scourge of older adults in the hospital. Who's had the experience of seeing an older relative or a friend go into the hospital and suddenly it's like someone flipped a switch? They're a totally different person. At least a few people. Yeah. So this is delirium. Delirium is an acute confusion that happens with medical problems. It's very common in the hospital. Sometimes we call it acute brain failure. Someone is confused, they're disoriented, they don't know what's going on. It's a huge problem when it happens. And you can imagine, and some of you have seen this, it's hard to provide good medical care for someone who is that confused. But then it also has long-term effects. It increases the risk of dementia a lot. In fact, it may be the single biggest preventable contributor to dementia in the population. And that's the good news, though. It's preventable. So you can prevent probably at least a third of all delirium by just carefully doing some of the very simple things we were just talking about. Sleeping at night, having natural light during the day, being up out of bed and active, being careful with medications, having glasses that help you see, having hearing aids if you need them, or a pocket talker to help you hear. It turns out it's easy to get disoriented if you can't actually see what's going on. The last time that I was in the hospital, I thought my greatest contribution to someone's healthcare was buying them a pair of reading glasses so that they could continue their journaling and read the books that they had brought to the hospital to keep their brain active. And I think that was really important in helping to prevent delirium for them and, helping keep them happier through the hospitalization too. But add up those little things and you can prevent a lot of delirium if you do them systematically.
So if somebody is facing a trip to the hospital, or maybe, a big deal like chemotherapy where they're going to be in the hospital visiting a lot, what can they do beforehand? What should they take with them to the hospital to give them a better shot at avoiding delirium?
This is why I love the 4 M's. So think about the 4 M's. And you can think about within each of those M's something that you can do before your surgery or before your chemotherapy. So mobility, probably the most important thing you can do to get ready for a big health stress is to train for it. Well, just like the Olympics, this is your Olympic event. You got to get ready for it. You wouldn't jump on the floor exercise without warming up and stretching and being prepared for it. So if you're facing a health stress, you want to be in literally better shape than you are right now. And that means being a little more active, maybe starting an exercise program with your doctor or a physical therapist, but being just a little more fit can make a big difference, a little more functional. Mentation, being in the best shape that your brain can be. So part of this is looking at your medications. We're getting into the other M now. And optimizing that list, taking off things that shouldn't be there, things that are causing problems, making sure you're on the right things for your medical problems before you get to the hospital. And what to bring with you. So bring a list of your medicines, bring all your medicines. Believe it or not, it's really hard for a doctor to know what you're actually taking. You'd think we could just ask the pharmacy or look at what we've prescribed. But it's a lot harder than that in reality. You are the best source for what medicines you're actually taking. And I love it when people hand me a list, especially where there's check boxes for when they're taking it every day. I love that. It's actually a huge deal for keeping you safe in the hospital. Bring an advance directive if you have an advance directive. If you don't have an advance directive, you should go home tonight and do one. There's a fantastic website made by one of my colleagues at UCSF called Prepare for Your Care. It's a really approachable, easy to use site that walks you through an advanced directive, which means who you would want to help make medical decisions if you were incapacitated, and what kind of decisions you'd want those to be. What are your goals? What matters to you? That's really important to bring with you too. Bring a comfortable pair of shoes, preferably slip-on, because I want you out of bed and walking around in the hallways, and you need to be wearing, good shoes to do that. And bring familiar things with you. Make that hospital room a little bit of home. Bring your favorite blanket. Bring your favorite sweaters. Bring some pictures. These things that sounds like, yeah, that's nice. It is nice, but it's also important for preventing delirium, believe it or not, because it makes that room a little bit less alien, a little bit less dehumanized. It makes it your space, and that's actually really important for your brain. And maybe most importantly, bring your advocate. Bring your trusted friend or family member. You're sick. You're going to have a hard time listening to everything. You're going to have a hard time keeping track, asking questions. Bring someone you trust with you who can listen to everything the doctors say, who can ask questions for you, who can keep track of things. And, when needed, who can pester the nurses and doctors. She hasn't been out of bed yet this morning. Can we please go for a walk? And to be that advocate. So there's really simple things that you can do.
Great. So now I want to get back to the 4Ms. I'm getting really great questions. I don't think we're going to be able to get to all of them, but there's a bunch of them here. How do you deal with a defensive doctor who thinks they know more, even though you have questions for them? My very young doctor is prescribing a statin, even though I'm in excellent health. Your thoughts, something they should talk to their doctor about. So I want to get back to these 4Ms. I'm going to get on a soapbox for just a minute. We really need to take our own health in our own hands. Really, really smart, great people on a national level came up with this. We all know how hard it is to change systems, especially the healthcare system. So we need to fill out the form and take it with us. We need to leave a blank form with our doctor and say, this is what I'm interested in. This is what you need to take care of older adults well. I think we need to push for it. Kaiser, a lot of us here are in Kaiser. Kaiser's very popular. Kaiser overall is one of the pioneer health systems who helped devise this age-friendly health system. The only facility here in the North Bay which is certified age-friendly is the medical center in San Rafael. But the rest of them haven't, they know, but they haven't got on board. So this is your chance to get your doctor, your health system to get on board. Thank you for listening to me. So John, but when somebody does, go to their doctor, they have their list, they get pushback, because doctors are busy and it's like, what are you giving me this? How do you deal with that? How do you deal with a doctor who's not quite yet on the program?
Well, you are in charge of your own health. First of all, remember that. Now, of course, the doctor's allowed to have opinions and we're supposed to have expertise, but we're also supposed to be making decisions together with you. And we call that shared decision making because your goals may not be the same as my goals. And that's okay. We talk about that. We come to a compromise. If one or the other of us feels very strongly about something, we should say so. This is the nature of having a trusted relationship with your doctor. And I know not all of us have that these days. I like to say to people, if you can find a geriatrician, that's great. If you can't find a geriatrician, the next best thing is a doctor that you've come to trust over the years and that you can have these kinds of frank conversations with. One thing that helps is to, I think about your goals and your priorities ahead of time and bring them with you. And the first thing that you should say when you walk in the door, maybe after hello, or maybe even before hello, is these are the priorities I'd like to talk about. And the doctor will probably have the things they want to talk about too. So the first thing you do is decide what's the agenda. You're not going to get to everything, neither are they, but make sure that you get to the one or two things that are most important to you. We are actually training doctors to do this these days. The doctors that in my program at UCSF, we teach them this is agenda setting, and it's a shared process. But not all doctors know about this, so you can teach them. Bring your agenda, and then realize that time is short. Things may be more complicated than they seem, so it's okay if you need to do things over several visits or push one to the next visit. That's okay. They're going to do the same thing.
So, as expected, this is perfect. What is your view on supplements for older adults? And somebody asked about your thoughts on melatonin. What do you recommend for insomnia? Big issue with older adults. So give us your take on supplements overall, and then maybe we talk about sleep a little bit.
Yeah, sleep is a great example of something that we all wish we had a magic pill for, because it's something that does, how we sleep changes as we age. Our sleep does change in structure. It becomes less restful at the same time that it extends. We spend more time in bed, maybe even more time sleeping, but less time sleeping in the most deepest restorative states. And boy, it'd be nice if we had a pill to just fix that. Maybe we will one day. Maybe that's an example of something that that geroscience, studying the basic science, the biology of why these changes happen in our bodies, may come up with solutions in the future that address at the root cause, the aging mechanisms that are causing those changes to sleep. But in the meantime, most sleeping pills probably do more harm than good in older people, mostly because they affect thinking, memory, dementia. So start just like we talked about with pain. Start with the simple stuff, because sometimes the simple stuff done deliberately and systematically helps a lot. Sleep hygiene, making sure that you're up and active during the day, that you're seeing natural light, even better, you're going outside, making sure that you have a routine for getting into bedtime sleep, things like avoiding caffeine late in the day, maybe avoiding too much water or wine later in the evening, that your bed is a restful place and that you don't do other, more stressful things in bed. Don't work on your laptop in bed like I do all the time. But these simple sounding things often can have as good or more effect than a medicine without the negative side effects. And in fact, they have positive side effects. If you're being more active and you're exercising more in order to help yourself sleep better at night, that's going to have positive effects on all sorts of other health problems too. So geriatricians like to think, let's start with, we call them non-pharmacological interventions. And they're a little more complicated than taking a pill. They may require thinking about how to adjust the way you live your life a little bit, but they can be really effective and don't have the same problems that pills often do.
So how about other supplements? How do you overall approach supplements, and should folks include those on their list when they go see their doctor?
Absolutely. Supplements can affect your health. I mean, that's probably why you're taking them. You're hoping they'll benefit your health, but they can have side effects too. So absolutely, your doctor should know everything that you're taking, all the supplements, all the herbals, all the extracts, all the vitamins, everything. Because sometimes those things will interact in important ways with other medicines. And the pharmacist, the doctor need to know that, and they can help to prevent a problem. Geriatricians, honestly, we're kind of minimalists when it comes to supplements. I have to admit, because supplements that have enough evidence behind them become medicines, even if it's the same thing. I think we have a pretty good sense of what are the best the people who benefit the most from taking vitamin D, for example. I think we have a pretty good sense of people that benefit from taking fish oil and when. And there are even like prescription versions of these. So, if there's enough evidence, a supplement suddenly becomes a medicine. But they're supplements often because we don't really know yet exactly how they might benefit someone in what contexts. Maybe they do, maybe they don't. A lot of supplements don't really do much harm. So, feel free. Some supplements do, though. There are some supplements and herbal medicines that can affect your blood clotting, for example, make it more likely that you'll have a serious bleeding problem.
Which one is that?
Especially if they interact.
Which one is that?
So I would
I want to know.
I would look on the Beers criteria from the American Geriatric Society, and they'll point out some of the more commonly used supplements that can be potentially problematic. So you don't want to do more harm than good. And to be honest, I sometimes I think if someone is taking a lot of supplements and spending a lot of money on supplements, well, if you have, if you can do that, that's okay. But I certainly wouldn't spend so much money on supplements that you're having trouble affording your medicines or affording your rents, or affording a nice vacation with your kids. This gets into priorities. What's the most bang for the buck, and what's going to most help you achieve your goals in life?
So I want to talk about your mind and sense of well-being. We got a question. What are the most important qualities of community that enhance the quality of aging?
That's such a wonderful question. So many overlapping layers we could talk about. The couple of things I'm thinking of, community in the sense of the people around you is so important for healthy aging. We talk a lot these days about loneliness and about social isolation and how these affect people's health. They're slightly different things. Loneliness is the feeling that you're alone. You're not really connected to other people, even if you're around other people. You can be lonely in a crowd, as people like to say. Social isolation is the idea that you are really physically isolated from other people. Maybe that's because your health problems have made you mostly homebound, made it really difficult to get out. There's not really people around you who can help out with things. These are both associated with serious medical risks. People who are lonely and people who are socially isolated are more likely to die than people who are not lonely and are not socially isolated. And they're problems that can be fixed. There's actually been clinical trials, believe it or not, of peer socializing support. So training older people how to be social friends, basically, but in a more structured, kind of medically helpful way with their peers who have serious medical problems. And that really just involves being there for someone, talking to them, helping them out with things when they need it. Not a whole lot. I mean, these clinical trials involve meeting once a week or something like that, and they make a huge difference in people's well-being. So loneliness and social isolation are big problems, but they're problems that can be solved. And then when I think about community, I think about the places we live, and how the physical structure and the social structure of the places we live makes such a difference for healthy aging. If we are in a place where we can interact easily with other people, where we can walk out of our house and do things outside, walk to a grocery store, be more active, just as part of our day-to-day life, because our community is built that way. That can be very helpful for healthy aging. It's not the way most of our communities are designed. Our communities are often designed to isolate us, whether you're in a walk-up apartment in the city that becomes hard to navigate the stairs, or if you're out in the suburbs and once you have a problem that makes it not safe for you to drive, you're really stuck and you're isolated as if you're in the middle of nowhere. So our communities are not always well designed, and I think if we put more thought into how we create our communities, that can have a huge impact on our health as we age.
Great. I noticed some folks very wisely wearing masks. I celebrate that. I think we would be remiss if we didn't talk about COVID-19, vaccinations, aging immune systems. What do we need to know?
Sure. Yeah, vaccines are, if you're thinking about how can I stay healthy and what are the highest impact things I can do to, live better longer, vaccines are way up there on the list. They're such low-hanging fruit. It's up there with, be more active in your lifestyle, get your cancer screenings, get your blood pressure screenings, and vaccines. And there's a bunch of, this is like a golden age for vaccines for older adults. There's a bunch of new vaccines that recently came out with huge benefits over their predecessors. And the COVID vaccines, I think, are an example of It was just it was a modern medical scientific miracle that we got such effective vaccines so fast. But they're still important and they're still relevant. So for older adults, remember the COVID vaccines are being updated every year for the new strains. So like a flu shot, you get the updated one. But unlike your annual flu shot, the COVID vaccines should be twice a year because COVID is still a slipperier, more mutating, tougher bug than the influenza. And COVID vaccines aren't just good for preventing problems from severe COVID. That's a big deal itself. But data from large studies in the United Kingdom, for example, are showing that it protects your heart. It can reduce the rate of heart attacks progressively with each vaccination. And this is not a surprise because, if you look back, we can see that when there's a flu wave, when there's a COVID wave, there's also a heart attack wave. Some of that is people with really bad infections, but some of it is people with mild infections. And it's just the low-level inflammation that viral infections cause. So, COVID vaccines have a benefit even beyond just COVID. I'm getting mine twice a year. There are some people with special health circumstances, but I think for the vast majority of people, I would recommend what most people do, which is keep up with your vaccines. And not just COVID. Anyone who's experienced shingles, I am sure, wouldn't wish that on anyone. There's been a shingles vaccine for a few years now, but it was partially effective. In just the last couple of years, there's a new version of a shingles vaccine with new vaccine technology. And first of all, it is much more effective, almost perfectly effective at preventing shingles. So even if you already got a shingles vaccine a few years ago, you should get the new one at some point. And I don't know if you saw this in the news, Chris, but just a few weeks ago, there was a bunch of news in the press about a big study in the United States showing that people who got the new shingles vaccine were less likely to get dementia. It reduced the risk of dementia, ballpark, about 25%. That's crazy. If there were a vaccine for amyloid or for tau, the proteins involved in Alzheimer's disease, that reduced the risk of dementia 25%, it would be the biggest news in the world. But it sounds like the new shingles vaccine might actually help to prevent dementia as much as almost anything else that we do. And it makes sense because the virus that causes shingles, lives in your nerves. It can reactivate when you're older, and that causes shingles. When it reactivates, it can go to your brain. It can cause inflammation in your brain. So it kind of makes sense, the idea that if you stop it from doing that, it would help to protect your brain. So yeah, vaccines are such low-hanging fruit. Vaccines for RSV, this is new, in the last few years, helps to prevent the other big respiratory virus. Probably will wind up having the same effects on the brain and on the heart that we see with other respiratory viruses. Updated vaccines for pneumonia, for bacterial pneumonias. Vaccines.
I love this question. First, thank you for being a geriatrician. And if you walk, eat healthily, and do a lot of the right things, how can you increase energy at 85? I don't take medications. What do you say to an 85-year-old who wants to?
Well, I will think first, is there any low-hanging medical fruit we could be missing? Medical conditions like a heart rhythm or a little bit, or heart failure, or, emphysema that could be sapping you of energy. And if that's, if that energy is the biggest problem in your life, maybe there's a key we can turn that would, not cause too much harm, but actually have a big impact on helping you. So first instinct is definitely, let's make sure we're not missing something that could be really impactful medically. And then if there's not, if really in good health, I would think, let's work on the basics. What's your sleep like? Let's try to work on that. And what's your activity like? And maybe, are you napping in the afternoon? Could that help? Make sure that we'll talk about what you're eating, what kind of food you're eating, what pattern, are there things you could be doing better in terms of nutrition that could help your energy? And let's not forget, how's your mood? How's your motivation? What are you thinking about, your life and your kind of purpose in life, because this affects energy too. And how are you interacting with other people? Um, there's there's some great research about purpose in older adults. It's pretty common, after you retire, and a lot of us are really tied up in the identities of our jobs, to float a little bit and to kind of lose track of what is our purpose. Why are we here on this planet? But if we can find a purpose, find a new purpose, that actually has real, concrete, measurable health benefits. Not just energy, but even things like reducing mobility disability and even reducing mortality. So I might even start to think about, what is your purpose, and tied up with what's your goals, what are your priorities, and see where we go from there.
So this question from an 85-year-old reminded me, I wanted to talk to you. We've talked a little bit about what tests people should get and how does age impact that? Are there particular tests we should ask for? How do we approach that issue?
Yeah. I think the most important thing to keep in mind is that age, meaning the number that's on your driver's license, doesn't determine any of that. Your age doesn't determine whether you should get a cancer screening test. It doesn't determine whether you should get a blood test for cardiovascular disease. It's about your priorities, and it's about your overall health and function. So, if you're an 85-year-old who's playing pickleball and enjoys picking up your grandkids, you're in pretty good health. You should probably be keeping up with most of your cancer screening. If you're a 65-year-old who unfortunately already has Alzheimer's disease, already needs help from other people in taking care of themselves, and maybe even is living in an assisted living facility, probably for you, cancer screenings are not your highest priority. So it's not about age, but it's about what's your priority and what's your overall health and function. But certainly the big things to think about are cancer screenings and cardiovascular screenings in terms of tests. And these can have benefits even pretty late in life. And there's more cancer screenings now than there used to be. Not as many as I would wish, but don't forget about colon cancer. Don't forget about breast cancer. Don't forget about cervical cancer, even if you're older. Prostate cancer is complicated. That's probably a conversation with your doctor for most of us. And relatively new on the list is lung cancer screening, if you've been a smoker. And there's a few other things, screening for abdominal aneurysms, again, if you've been a smoker. But these are also low-hanging fruit. These are basic preventative care that can make a big impact on your life, especially if your window on life stretches out quite a ways yet, because you're in pretty good health.
So this leads me to the question I told you I was going to ask this. So what should somebody say to the doc who tells them, well, what do you expect at your age?
Time to look for a new doctor. I don't know. I'll tell you, one of my favorite primary care patients back when I was a fellow was an older gentleman with pretty advanced Lewy body disease, and he was in a wheelchair, and he had some dementia too, and he came into my clinic with his caregiver pushing him every day, but whenever he came in, I would ask him, "How are you doing today?" And he would always give me exactly the same answer, which was, "Doc, I'm doing the best I can with what I got." And I think that's the answer. No matter whatever your age, whatever your aging is, it's always okay that you want to do the best you can with what you got for as long as you can. And I think that's another way you can answer a doctor who says that.
That's great. Okay. Jordan, can you advance the slide? I think we were on this one for so long. So how to talk to your doctor. We've talked about some of this, but let's do a recap.
Yeah, these are some questions to keep in mind. Just ways to think about how can I talk to my doctor the way that a geriatrician would. What matters most to me? Think about that before you go, and think about that in the specific context of a decision. Like if we're talking about a surgery, if we're talking about new medicine. What matters to me and how will this help to accomplish that? And similarly, what's the goal of whatever it is we're talking about? Before we want to make sure that we're just not knee-jerk prescribing a medicine because we can. But what's the purpose of that? What's the goal? What are we trying to accomplish? And then does it make sense with my priorities? Should we still be doing this? I recommend every year or two you do a spring cleaning of your medication list with your doctor, because your bodies change, your needs change, and maybe you don't need something that you were taking a few years ago because the problem has gone away, or maybe it's just not the right thing for you. Maybe it's more risky than it used to be. So should we still be doing this? We change. And everything affects everything else. So anytime that you're thinking about a change, how is this going to affect your other medicines, your other medical problems, and ultimately your goals? Everything affects everything else. And most importantly, not just is this something that we can do, but is this the right thing for me to do? Is it an important thing for me to do? We can't do everything. We have to prioritize. The hard part is figuring out what's most important. So is this the right thing for me right now to help me achieve one of my goals?
So back to, should we still be doing this? I remember you and we talked about zombie drugs.
Yeah.
So when folks are in the hospital, so what's a zombie drug?
Well, so hospitals are a famously bad time for your medication list. It's very easy to get things changed. In the hospital, the doctors aren't really sure what you've been taking. And then when you leave, they change a bunch of things, and then your primary doctor is not sure what you're supposed to be taking. So it's a really high risk time for medications. And one of the things that often happens is something will be started in the hospital, maybe for a good reason while you're in the hospital, but then it stays there. A common example of this are antacid medicines, like PPIs. So often they're started in the hospital. Sometimes that's for a good reason, to try to prevent bleeding when you're in that stressful environment. But then they stay on your med list. And then a year later, 2 years later, 3 years later, why am I on this? Have I ever had an ulcer? Do I have a reason to be on this? And often the answer is no. It was started for some reason that made sense 3 years ago, but doesn't anymore. It's a zombie medicine. So that's a perfect example of, that's not the right medicine for you because you don't have a good reason to be taking it. So you're getting all of the potential harms, but you're not actually benefiting from it because you have no reason to benefit from it. So that should be taken off. So do a spring cleaning every year or two. Should you still be taking this? Does it still make sense?
That's great. Next slide, Jordan. Okay, so in the beginning, when I introduced John, I said his lab is working on developing interventions for older adults. That science is moving into clinical trials here at the Buck. So I'm going to have John talk about them briefly. I just want to let you know this is kind of a tease because our October community seminar is going to be all about our clinical trial program. I want you all to come back for that. And there's going to be some folks out in the atrium afterwards if you want to ask some questions about our clinical trials. But John, what's the overview? What's the overall goal of clinical research here at the Buck that you actually have been really instrumental in getting going?
Well, so the big picture, and now we're finally talking about the science.
Yes.
The science is inspired by my own, clinical experiences in trying to prevent and treat these complex multi-system problems of older adults, geriatric syndromes. And the science of the biology of aging, geroscience, I think, is a perfect fit for geriatrics, because all of a sudden the problems don't seem so complicated if you realize that they're all caused by a common set of cellular and molecular functions that drive aging. And we know what these cellular and molecular drivers of aging are. And we can manipulate them in the laboratory. We haven't made a mouse live forever yet, but we've made an awful lot of mice and rats and worms and flies much healthier by manipulating their aging at a molecular level. That sounds crazy. But this is the state of the science. And it's ready to move into the clinic. It's ready to move into clinical trials to see if we can apply this aging biology, this geroscience, to help to improve these complex conditions that older adults face. And that's what I'm trying to accomplish with my science. And that's why we started a clinical research program here at the Buck, to focus on testing out some of the molecular mechanisms of of things that emerge from science at the Buck to see if they're relevant in people and to see if we intervene on some of them, can we improve people's health? So, for example, I'll point out maybe two of these studies. Molecular optimization via exercise. We all know exercise is good for you. We all know exercise is good for aging. Why exactly? And if we can figure out why, can we turn that into targeted therapies to help people get the benefits of exercise who, for a variety of health reasons, aren't able to exercise the way they used to? So MOVE is going to study older adults who are elite athletes and have been for most of their life. And we're going to carefully characterize how that has affected their aging at a molecular and cellular level. And so try to figure out what are really the deep molecular benefits of exercise. Takeoff is a little different and even a little more practical, maybe. My lab studies the science of ketone bodies, a fuel that your body can use instead of glucose to help to support its energy needs. And we think that this is important in aging, that your body actually starts to rely a little bit on ketone bodies. We're not talking about ketogenic diet even, but just normally. Your body makes a little more ketone bodies, and that helps to support your heart and your brain. We want to find out if you give someone ketone bodies, an older adult, can that help to improve muscle function and brain function in frailty? One of these complex geriatric syndromes that's driven in part by a lack of cellular energy. So this is a study where we're going to ask participants to take ketone bodies for 20 weeks for most of half of a year. And then both characterize how that affects you at a molecular and cellular level. What is it changing in your body? And also, does it make you stronger? Does it make your thinking faster? Does it make you more mobile? To see if we can actually, concretely improve people's lives with some of these geroscience-focused interventions. And I hope that, the goal is to grow the clinical research program at the Buck so that we can really become a hub for moving the entire field of geroscience forward, moving things out of the laboratory and seeing what works in people, and then helping to figure out how to actually turn that into clinical practice that will help to prevent chronic disease, that will help to prevent and treat geriatric syndromes, and that will keep people healthy and independent for longer.
All right. Next slide, please, Jordan. All right. So I want to thank John for being here. A great event. Thank you so much for your participation. So here's what's going to come next. You're going to get an email either later today or tomorrow that has all the links, more links than you're even expecting. Believe me, I want you guys to have all the information you need to move forward. I want to encourage you to come on a tour, especially if you're new to the Buck. We have public tours on Tuesdays and Thursdays. You can sign up for them on our website. We have a great podcast. We're not getting any younger yet. All right. Yeah, it's great. This latest one features Nathan Price, who's our newest faculty member. He's going to be arriving here soon. So it's a good show. It's worth a listen. Next slide, please. I think this is our final one. So I'm going to be back here on September 4th. I'm going to be hanging out with Dr. Pankaj Kapahi, one of our faculty members. He's going to be talking about Eat Your Way to Extra Years Nutrition and Healthy Aging. Sounds yummy to me. I hope you're here and joining me for it. So once again, thank you so very much. Get excited about this age-friendly healthcare system. We all got to get behind this. We need a new movement to get this happening. So thank you so very much for being here.